there's just a little tip that in order to feel more rested, we have to put our electronics down. And I found something on Netflix. I don't know if some of you might be interested if you do have Netflix. It's kind of in a cartoon way, only because I see so many children too playing with their phones, and they don't put their head up. And I think it's important that we understand that it's a problem. It's a big problem. But anyway, there's 7 episodes of this on Netflix. It's called Headspace Guide to Sleep. And it kind of gives many topics. It's short. It only lasts, the longest one is about 20 minutes long. And I was able to watch all of them, and it gave really, really good information as far as being mindful, what to do to help, with sleep, putting your electronics down 30 minutes before you go to sleep, using breathing exercises, the Calm app. There's a Sleep Better app. So, just going through it, it made me think that I know that a lot of us, sometimes we bring our work home and it's hard for us because we're anxious for the next day. And so I just wanted to put this out as a tip for the month in how to sleep better. And there's also another one with meditation. And what I learned too is that some insurance companies offer the app on their site, and you can download it there and use the app there too, because I know some of the apps do cost a little bit of money. But then that's the tip for the month is, for us to sleep better so that we could be more energetic in the morning when we're doing our most important jobs.
Thank you.
Welcome.
Thank you for that reminder. We can all cope better when we get all the sleep we need. Great, thanks. All right, and next up, we're gonna have Lori talk about COVID. So we let Lori share her screen.
Okay, thank you. Let me get my screen up and ready for you. Okay, so hi everybody. Thank you for being with us today. And so I'm just going to catch us up on the COVID related news since we last met. So on June 14th, CMS released a memo stating that surveyors will continue to ensure that the staff vaccination requirement is being met during the initial and recertification surveys. But now it's only when there's been a complaint regarding non-compliance with the requirement. So they're not going to be looking at this in all surveys anymore. And then they're also revising the QSO memo. It's 22-11, and that is to ensure that our deficiency determinations reflect good faith efforts that providers and suppliers have put in place. So they're updating the interpretive guidance for surveyors, and in that they're describing immediate jeopardy, condition level, and actual harm determinations. And then they're recognizing good faith efforts within that, and to more fully evaluate harm or potential harm to residents by considering the trends related to COVID-19 rates in the community. So another thing to note is that CMS stated that nearly 12,000 of our providers and suppliers have been surveyed for compliance since this vaccine requirement went into effect in February of this year. And out of those 12,000 providers and suppliers, 95% of them were found to be in substantial compliance with this. So again, they're just moving this now to only address if there's a complaint of non-compliance. And then beginning with the reporting week of June 27th, the National Healthcare Safety Network updated its definition of up-to-date with COVID vaccines in response to the CDC updating its definition of up-to-date for certain individuals. So on June 23rd, CDC hosted a webinar reviewing the changes, and I've added a link to the presentation materials where you can access the definition. And then they also gave example scenarios in that webinar and how to report them. So those are included in the presentation. And I'll include these links in the chat section for you. And then taking a look at our community transmission rates as designated by the CDC. So again, the CDC looks at two metrics to determine this. They look at the new cases per 100,000 over the last 7 days, and also the percent of positive tests over the last 7 days. And of course, as you can see, all of Hawaii falls in the red, which places us at a high level of community transmission. And therefore, we know that all our nursing facilities are following that CMS requirement to test staff who are not up to date with their vaccinations at a rate of twice a week. And then I pulled this information yesterday from the Hawaii Department of Health on their website. And so this data is as of July 4th, and you can see our good news at this point is that statewide, our 7-day average of cases is going down. And you can see that here also reflected in the statewide epidemic curve. So our next 3 slides are from La Lima Data Alliance, and it allows us to take a look at what's happening in our hospitals. So this one shows the total confirmed COVID-19 patients in hospital beds in our state. And you can see that after our Omicron surge here and then the Delta surge, Omicron, we went down in cases in February, and then in late April to early May, our numbers started to rise again. And it's really hard to see on this slide because we've bounced up and down a little bit right here, but we are starting that downward trend. ICU bed usage across the state of Hawaii has remained fairly low throughout this time. It did tick up, as you can see here, just a little bit around the peak of mid-June, but again, we're trending down from there, and we are hoping that that continues. We certainly haven't seen the volume that we did in the previous surges. And then as far as the total new COVID admissions per day, again, our peak around mid-June, and it's going down. So I have a little bit of a lag with this data. This is from looking at a period of June 9th through June 15th of this year. So at that stage, Hawaii had the second highest rate of confirmed infections per 100,000 individuals. This is in the nation. And for the 3 weeks prior to this, Hawaii actually held the top spot with the highest confirmed infection rate. But still, when you look at the overall duration of the pandemic, and they count that as March 7th, 2020, and on this slide through June 15th, Hawaii continues to have had the lowest infection rate in the nation. And again, for that week of June 9th to June 15th, Hawaii had the 30th lowest death rate per 100,000, but overall, for the entire duration, we have the lowest death rate. And we are right there with Vermont at the bottom there. So I just wanted to share that information with you, kind of show where we're at. And Dr. Nguyen, I'll hand that back over to you.
Yeah, I see Maria has a question. You want to go ahead and ask?
Yeah, I have a couple questions. Now I'm trying to remember what the second one was, but the first one has to do with the vaccination requirements, because this came up as a question. When the vaccine mandate first came out, we had like a 30-day, a 60-day, and then a 90-day phasing compliance. And by the 90 days, people just had to be fully vaccinated or exempted, right? So when you have somebody, an employee that you're hiring, if they are not coming in fully vaccinated, like they've only gotten one vaccine, we can't hire them until they're fully vaccinated, because we would be out of compliance right away. Because I don't see in that reg, that memo that they sent out, that there's any phasing in of new employees. It's like after that 90 days, it's all or nothing. They're either fully vaccinated or they're not. So I was just wondering, is there something about new employees having a certain amount of time if they've started the process to get fully vaccinated, or we either hire them and we're out of compliance, or we can't hire them until they are fully vaccinated, which is 2 weeks after their second, right? Does anybody know for sure?
You know, from what I understand, you're exactly right. I haven't seen anything on timeframes for new employees. I just have seen in this updated guidance, they are saying to follow the recommended timeframes, whether that's, you know, with the initial 2-dose and then, you know, the follow-up timeframe with the boosters. And then they have the additional doses, right, that they indicate after that. But I haven't seen anything specifically talking about new hire. Everything is, if they are not considered up to date, then you need to show that as a facility, you're testing according to these CDC guidelines for community
That was my
transmission.
second question. Oh, good. Okay, so CDC in their guidelines, if and when we ever get to a low community rate, they don't recommend testing, even the unvaccinated. But I think CMS requires at least weekly testing for those that are not up to date and not vaccinated. Is that accurate?
I'm going to ask Dana if you know about that, Dana, because what my awareness is this guidance for CDC testing, right? That you have to look at the transmission rates in your community, and that informs the rate of testing that you should be doing in the facility with those staff members who are not considered to be up to date. But Dana, do you know anything different from that?
No, CMS has a tendency to refer back. They refer back to the CDC testing by community transmission rate and based on your vaccination rates. And I also want to comment. Oh, go ahead.
I was looking at that memo because it came up trying to figure out if we could hire somebody that's not fully vaccinated. And I thought in that same memo is where they were saying, you had to make these accommodations for the people that are exempt or not vaccinated. And I thought they included weekly testing as one of the things. And I don't know if it was just a suggestion or if it was a requirement, but that's what got me thinking. It's like, I mean, we are doing twice a week anyway. And I think our mitigation plan, we did just leave it in. If they're not vaccinated, we will continue to test them at least weekly. But I'm trying to figure out if that's
saying regardless
of
transmission rate. You think you saw that somewhere?
Yeah.
I'll see if I can dig that up for you. The one thing I was going to comment on is on the original vaccination QSO, and I'm not sure if they changed that, but they had language in there that said if you have folks that aren't fully vaccinated, you have to document that you have a plan for getting them fully vaccinated. And then you've got to follow the guidance for whether they work directly with patients or not. So I think that covers you from getting cited as long as you can document that we know when they had their initial shot, and we have a plan to have a vaccination clinic or whatever in this many weeks, and they're scheduled to get that, then that should appease your survey team because you've got a plan for getting them up to date.
Yeah, I thought that was in that 30, 60, 90 day thing, and I didn't see it after that. That's why I was wondering. Because then we have students too, right? So there's a group of students, and a student has only had one vaccine, and they're saying, can they come in? I'm like, no. But I don't want to deny anybody their education. I just don't want to report in NHSN that we've got unvaccinated people in the building because here comes DOH. And
right. But let me compare those two, because I thought that language still was appropriate for what they've sent out recently, that you have to have a plan, because it doesn't make sense to close your doors completely to people who aren't vaccinated. You may have to make work accommodations for them, but I mean, not that CMS always does stuff that makes sense, but with how we're struggling with staffing anyway, that seems really counterintuitive to not allow you to have that plan to make sure that people get vaccinated before you put them with patients or residents.
Yeah, that's my understanding as well. It's all about the documentation, right? And with surveyors, it is all about the documentation. If it's not documented, it didn't happen. So my understanding is as long as you have that in writing, you can put that before them. And now they are to take that into consideration as a good faith effort when the surveyors walk through your door. So
Right. That's what we're relying on, good faith effort, good faith of the surveyors, if you trust them. Okay.
It's subjective still, but
shall we move on? We're going to talk about falls. So John, we can, this is our next series, falls. What should we do? So just get to the slide number 11. Definition, we know what a fall is, right? Unintentional change in position coming to rest on the floor or next to, on the next lower surface. So on a bed, chair, bedside mat, whatever it is. Sometimes the fall is witnessed, sometimes it's unwitnessed, sometimes it's reported by a resident, sometimes reported by the observer, sometimes you just find them on the floor and you have no idea how they got there, right? All right, next slide. But, you know, really, we don't want to be behind the 8 ball. We want to sort of be ahead of the game a little bit and, you know, prevent falls. And so the way, you know, we like to think about falls is, you know, there's outside risk factors and inside risk factors. The inside is, you know, the patient themselves and the comorbidities and all that sort of stuff. But we want to, for sure, try to minimize the outside risk factors. So just be mindful about the environment. Is it unfamiliar? Are we using restraints, which we don't want to use? Are there additional tubes or lines which are considered restraints in some way? Because it does limit their mobility, you know, brakes that could lead them to be unstable, wet floors, footwear issues, poor lighting, or furniture that blocks the way and creates a obstacle course. Next slide. Or there are inside factors like being older, having a falls history. That's kind of number one. Asking if they have fear of falling, and have other comorbidities like high-risk medications or medical conditions, which the physician and the pharmacist will overview and try to optimize the management of those conditions. But then here's the big one, right? The physical weakness and the cognitive judgment. That's what dogs all of us, right? And because a lot of them have this problems with weakness, endurance, balance, or gait, or, you know, cognitive issues where they have difficulty with judgment, or they're just wandering and they can't stop, and really needing to think about other alternatives to manage the cognitive disability with activities or supervision. I wanted to just touch base a little bit on the use of simple screening tools. So you can, you know, get on it and maybe get a physical therapy consult or something like that before falls happen. So next slide, we're going to talk about the use of simple screening tools. Anybody try this? A sit to stand. It's super simple, right? Sit to stand in 30 seconds. How many can you do, right? And so I'm going to have, and then the next one is the time to get up and go test. And so I'm going to have John play the very short video clip there, like a minute and a half or so. Just a brief demo. Go ahead. Thanks, John.
Chair stand tests functional lower body strength. To administer this test, you'll need a chair with a straight back and a stopwatch. Place the rear legs of the chair against a wall so that it cannot slide backwards. Have your patient sit towards the front of the chair and fold her arms across her chest. Ask her to keep her feet flat on the floor and sit upright. She should try to stand up, keeping her arms folded across her chest without pushing off with her arms. When you say go, she should stand up all the way and then sit back down, doing this as quickly as she can until you say stop. Arms should remain folded across her chest throughout the test. Stand close enough so that you can catch the patient if she loses her balance. If the patient gets tired, she may rest, but let the time keep going. If she cannot stand even once, the test score is 0. Not being able to stand up from a chair without using one's arms to push up indicates a high risk for falls. Record the number of times the patient stood up in 30 seconds. If the patient is over halfway to a standing position at the end of 30 seconds, count it as a stand. Now, based on the age and sex of your patient, find their normal range on this chart. If your patient's score is below the norm for his or her age and gender, It indicates lower body weakness, a risk factor for falling. If the patient can't stand up even once without using her hands, allow her to push off using a hand on the chair. Be sure to document any adaptations. The test score is still 0 for purposes of comparing to normative standards, but this way her personal performance can be evaluated from one assessment to the next. I find this test is very helpful for monitoring the effects of strength training. It's also useful for motivating patients because they can see how much they improve by doing strengthening exercises on a regular basis.
Dr. Wayne, you're muted.
Sorry, next video, please. Yeah.
The timed up and go, or tug, tests functional mobility. To perform the test, you need a chair and a stopwatch, or a wristwatch with a second hand. Have your patient start by sitting on the chair, feet flat on the floor, one foot slightly in front of the other, and hands on the armrests of the chair. Put a line on the floor 10 feet or 3 meters away. Ask your patient to stand up from the chair and walk at her normal pace to the line on the floor when you say go. When she reaches the line, she should turn around, walk back to the chair, and sit down. Be sure to start timing on the signal go, and even if your patient has not started to move, and stop timing at the moment she sits back down in the chair. While she's walking, stand between the chair and the line in case the patient loses her balance and you need to assist. Observe and note the patient's posture, width of the base of support, step height, stride length, arm swing, and path. When the test is complete, record the time. Also record whether the patient used an assistive device, and if so, what type. A community-dwelling older adult who takes more than 12 seconds to complete the tug is at increased risk of falling.
Thanks for the demo, CDC. So that's a really simple video that you could probably show your staff, and it's something really easy to do with the residents to just catch people before if they're having increased risk for falling. Okay, next slide. Falls case scenario, very typical, right? Mr. Liu, 82-year-old man, recently transferred to the skilled nursing facility after a UTI. He had dementia, he's redirectable, he has history of stroke, dementia, heart disease, hypertension, atrial fibrillation, and benign prostatic hypertrophy. He has no history of falls, but uses a front wheel walker and has been working with PT daily. He's on a bunch of medications, including metoprolol, lisinopril, tamsulosin, and Ambien, those kinds of drugs. And he is code status is full code. The CNA found him on the floor, sitting near his bed, front wheel walker within arm's reach, no signs of injury, and his mentation seems back to baseline. And vital signs seem okay. Next slide. So are you gonna call the doc? Well, before you call the doc, make sure we get all the information that we need, right? So if you guys have heard of SBAR, that's a form of communication tool that is helpful for making sure you don't forget anything. So make sure you complete the relevant aspects of the SBAR form, check those vitals, the relevant ones, look for signs of injury, review their record, make sure you take a look at their notes or consults or labs, recent labs or med changes and other pertinent orders, and take a look at that indirect care path or acute change of condition card if indicated, and then make sure you have a medication list especially available. Next slide. One of the things I love to do is ask the aides, have you noticed anything, right? Who are the ones who see changes first, right? If the nurses, aides, or the nurses, even the families, right? Are they little bit different than usual, talking a little bit less, needing a little more help, or they're having little more issues with appetite or bowels or drinking, a little more agitated, a little more tired or weak or confused or drowsy. These are all signs that something might be brewing, like delirium or something like that, that you should catch early to prevent falls. Or it might be a cause of the falls that needs to be treated underlying condition, a treated underlying condition. Next slide. This is an example. This is the Interact care path to falls. There are different kinds of care paths. And so I'm going to go through this in a little bit more detail. Next slide. Yeah, so for your evaluation, this is just the first half of that form, right? If a person has fallen, right, make sure we check those vital signs, and if those vital signs meet any pertinent criteria, such as, are they having a low-grade fever? Are they having a tachycardia, heart rate being too high or too low? Is the respiratory rate a little bit off? The blood pressure's systolics below 90 or over 200. These are red flags, right? And if any of these red flags are met, you need to call the doc right away, right? And then the other thing to do, other than checking vital signs, really important, also see if they're hurt. Don't move them from the floor until you've done a complete exam and make sure that there's no fractures, no head trauma. How's their level of consciousness? Are they more confused? Do they have any lacerations? Things like that. Just make sure, see if they're hurt at all. So those are the main things. Next slide. Yeah, and I just want to talk about the importance of orthostatic vital signs. Sometimes nurses are great and they just give you the vital signs, but especially after a fall, I think it's really important to do the orthostatic vital signs, because it'll give you a clue as to maybe they, fell because their blood pressure dropped, right? And so this is the correct way to do the orthostatic vital signs. And so I just put a little example here, for example. So check the blood pressure and pulse after lying flat for 5 minutes. So they're lying down, they've equilibrated, and say it's 150 over 85 with a pulse of 80. And then have them sit up, and then the body's baroreceptors adjust a little bit, 140 over 80, pulse 85, and then have them stand. Check your blood pressure again and see if it drops, right? And check it immediately and check it after about 3 to 5 minutes, and hopefully it'll, maybe it might drop, but maybe it'll come up a little bit. Let's see if we're left with. And if you're left with something like 130 over 80 with a pulse of 90, that means the systolic has dropped about 20 millimeters of mercury, and the diastolic has dropped 5 here, or if the pulse has increased higher. But because the blood pressure has dropped about 20 points, then this person would be considered orthostatic. You might want to ask them, do you feel dizzy, lightheaded, or faint? Take a look at them. Are they sweating? Are they pale? They have a cold sweat? And also take note if the blood pressure drops within 2 hours after a meal. Sometimes people get what we call postprandial hypotension. All the blood from the brain pools in the stomach after a meal, and then that also draws blood away, and people are higher risk for low blood pressure at that time. And of course, if you do find that systolic blood pressure has dropped, they're dizzy, or they're really low with systolics less than 90, put them back to bed, lie down. That's the first thing to do. And they are definitely at increased risk. But that's one of the things that doctors are going to be very interested in finding out. Next slide. So just make sure you do it correctly. And then this is the, 10 questions, right? When a resident falls, ask them, how are you? What were you trying to do? What was the circumstance? What is different? How come you do this all the time, right? You always go to the bathroom. What was different this time? You always use the call light, but you didn't this time. What was going on? And take note of the environment, as we talked about before. The environment is very important, that to identify preventable things. What was the surrounding light? What was the floor like? What were they wearing on their feet? Any use of assistive devices? Did they have glasses or hearing aids on? What position are they in? Because that will give you a clue as to how they fell down. How far away they were from the walker or the bathroom or whatever it is. And who was in the area when they fell? Was there anybody who observed it? And of course, all this stuff needs to be documented in your note. Probably have an incident report to file, as well as an assessment after the fall. Next slide. And then, of course, we prepare with SBAR. So I'm just going to walk through what SBAR is. Next slide. So, for example, the situation is I am calling about Dr. Wen's patient, Mr. John Liu. Jonloo. Patient's code status is full code. The problem I am calling about is a recent fall. Next slide. This is the background. Mr. Liu is an 82-year-old man who was admitted 4 days ago to SNF for urinary tract infection, history of stroke, dementia, heart disease, hypertension, AFib, and benign benign prostatic hypertrophy. He's forgetful at times, but he overall follows directions. He uses a walker. He has been working with PT, taking 100% of meals, having BMs daily, and there are no new medications. But these are his medications. Of course, there are some concerning medications. Next slide. Assessment, right? Assessment includes all those vital signs, right? And so you take it and you see, oh yeah, his blood pressure lying down, heart rate, respiratory rate. And John, if you click the return button, there is a bonus. You should check your orthostatics and click it again. And lo and behold, his blood pressure is, oops, go back. His blood pressure is 100/75. Notice that went from 120/78 lying to standing 100/75. That is considered orthostatic, right? So that's an important piece of data for the doctor. This happened at 10 p.m. He's sitting on the floor, unwitnessed fall. He misstepped out of bed while trying to get to his walker, trying to rush to the bathroom. Those are his circumstances. Fortunately, no evidence of head trauma, loss of consciousness, no change of mental status, no lacerations, no fractures. Heart sounds are fine, no evidence of new fractures or stroke or acute decline in ADL as he's awake. He has some mild buttock pain, but otherwise doing well. Click on that. Next slide. So it's 10 p.m. Do you call the doctor with that? Not necessarily, right? So you might want to refer to those uniform call guidelines and notice that we showed you on that care path, right? That, well, the vitals were actually okay. He wasn't having a fever. His heart rate were in good range. His respiratory rate, his blood pressure, O2 set, everything was in good range and no new abnormalities. So he seemed okay, no injuries. So maybe we'll just call the doctor in the morning with all the data and then we'll figure out what to do to prevent this fall from happening again, because clearly something different needs to happen. It's not like, 2 in the morning kind of a thing. Next slide, click. Okay, it's okay to wait in the morning in that situation. Other times, if it's got the red flags showing everywhere, you definitely need to call the doctor. And then you would talk to the doctor about the recommendations. And for that, it might be also helpful to use the Interact Care Plan again. You go down that form and you'll notice that there are other oh, look, there are the signs and symptoms for immediate notification. Those are the things that I talked about. Those are the red flags that we need to look out for that you need to tell the doctor about right away. And then considering asking for the following orders, like, well, yeah, so we had some abnormalities here, some red flags. Do we want to get a CBC? He's had urinary infection before, maybe we're concerned about low blood pressure and dehydration, get a BMP, his heart rate is a little off, maybe get an EKG or a chest x-ray or a urine culture, right? So those are some of the recommendations you might use. So you might say, I think he's all right, maybe just a bit of buttock pain. Can I give Mr. Liu some Tylenol? Or would you like us to monitor his vital signs or check his orthostatics, Q shift or neurochecks? Or maybe you want us to push some fluids on him tonight and then recheck his orthostatics again, something like that. And of course, make sure we have a plan as part of the recommendations on how to monitor this patient. Next slide. Then it's the doctor's turn or the NP, right? So after you tell us all the vitals, their condition, their symptoms, their problem list, their medications, and the circumstances, right? We need all this information so we can target the medical evaluation. Just to report that patient fell and there was no injuries is not going to cut it, right? So we need to have all of this stuff so that we can think about, because if they fell once, very high chance they're going to fall again. Next slide. So what's the doctor going to do? A physical exam with a special focus, including that orthostatic vital signs, and thinking about the heart, cognitive, balance, strength, neurologic exam, looking at their feet or their footwear, things like that. Next slide. And then, of course, also ruling out medical illnesses, because we know things like infections can, or dehydration and things like that can cause them to be more vulnerable to falling. So yeah, so we might want to be ordering labs. Next slide. And of course, we will also consider other medical conditions like vision, motor weakness, cognitive impairment, urinary incontinence. That's a huge one, right? A lot of folks are running to the bathroom, and that's why, that's the underlying problem. If we can kind of take care of that or make that a little bit better, they might run less often. Make sure they're not having any stroke problems or weakness from the stroke, cardiac issues, neurological disorders like Parkinson's disease, right? How do we optimize that, right? Diabetes, seizure disorders, or arthritis, right? How do we, if they have difficulty getting their functional incontinence, right? Because of mobility issues, then that increases risk for falls too. Next slide. And of course, doctor will consider high-risk medications and may review with the pharmacy too, thinking about all the drugs that could cause low blood pressure, drops in blood pressure, dizziness or sedation, low sugars, anything like that, can cause increased risk for falls. And so really needing to really tweak that. This person has several medications that put him at a high risk. And so, I would really be working with the staff to just tweak all of the meds to minimize those risks and make sure we push fluids on him. Next slide. And then of course, physical therapy referral if indicated, and the physical therapist is going to make sure we evaluate the footwear and look at their assistive device if they need one, or if their one is still appropriate, any other safety evaluation modifications, toilet risers, bedside commode, urinals, anything that we could help with minimizing that risk. And perhaps they might even need more assistance and supervision. Of course, caregiver education. Next slide. And next week, if you stay tuned and you come back, we're going to have a physical therapist on our team here. And we'll talk about the kinds of exercises that might be recommended. And we'll talk about how we can help the patient be successful with PT. We can be a team together and help improve their functional abilities and reach their goals. Next slide. And then I'm going to have Dana join us here at this point and talk about some regulatory concerns that our company falls.
We set the most exciting part for last. Yeah, so I wanted to, as we get started on this whole next series, just kind of level set us on some of the tags that relate to contributing factors for falls. And so we'll get through this, and then hopefully going forward, we'll have more exciting things to talk about. So one of the things, the first one we wanted to talk about was the survey guidance for bed rails and restraints. A couple of the F tags that they will cite you on related to these fall under F603, which is freedom from abuse. And it includes, but it's not limited to, freedom from corporal punishment, involuntary seclusion, and any physical or chemical restraint that's not required to treat a resident's condition or medical symptoms. And then 604 covers respect and dignity. It also covers freedom from restraints and freedom from abuse. The intent of F604 is, like they say, kind of for everything, which makes sense, is that it's the requirement that each resident attains and maintains their highest practicable well-being. And in this case, they want that in an environment that prohibits the use of physical restraints for discipline or for staff convenience, prohibits the use of them to unnecessarily inhibit a resident's freedom of movement or activity, and limits it to circumstances in which the resident has a condition or it's, symptoms that warrant the use of restraints. You've got to use the least restrictive restraint available for the least amount of time and continue reevaluating the need for that restraint. Next slide. So it all goes in as part of a person-centered assessment. So what we're looking for is, what are your symptoms? What are the medical symptoms that you're treating by using bed rails? This is bed rails specifically being looked at as restraints. Does your resident have, you must be aware that impaired cognition in your resident increases their risk of serious injury or death from entrapment or falling over rails. We've had that happen, and that's terrible. If partial rails are used to assist a resident getting in and out of bed, you have to make sure they can easily and voluntarily get in and out of the bed with those rails being used. And the question always is, does the risk of using the rails outweigh the risk of not using them? So, for example, considerations for residents could be a resident who has an involuntary movement may still have involuntary movements, and that combined with that person's weight and the type of bed that you put into place might lead to their body shifting towards the edge of the bed, which can increase their risk for entrapment. So we're always kind of thinking big picture. If your resident can't easily and voluntarily release the rails, they may be considered to be a restraint. And I pulled out the IJ example that they have in the state operations manual. Is this example, this situation. The staff recorded on admission that a resident was high risk for falls, and as a result, they placed full bed rails on all open sides of the bed. There wasn't, no assessment was conducted related to the use of the bed rails or the use of restraints. Documentation in the record revealed the resident crawled to the foot of her bed while the full bed rails were in a raised position, attempted to stand and walk, and fell off the right side of the bed. She was hospitalized for surgical repair of a femoral neck fracture. Gives you a scenario anyway. Next slide, please. So when you're considering the use for bed rails, obviously you want a comprehensive assessment that's going to include all of these things: medical diagnoses, their size and weight, their sleep habits, again, like Dr. Wen mentioned, any medications, any medical or surgical interventions that they've had acutely, what are their underlying conditions, anything that's going to, affect their ability to move or their ability to manage a bed rail. Next slide. So considering your risks and your hazards to using a bed rail, again, it could be a barrier to getting out of bed safely. So if they attempt to climb over, around, between, or through the rails or over the footboard, it's an accident kind of waiting to happen. Any part of their body that could get caught between rails or in the opening of the rails or between the mattress and the bed rails could be a risk for an accident. We talked about barrier to getting out of bed safely. If they crawl over rails or crawl to the foot of the bed, they're falling from a greater height. That can really increase the risk for serious injury. I don't know, I'm going to detour a little bit. Dr. Wen, are you familiar with Patricia Quigley? I think she's a PhD nurse who works for the VA. I believe she's in Florida. And she's a national falls expert, and her team put together videos that I should see if I can track them down. But they did videos with dummies falling, kind of pushing them over the sides of beds in various configurations, with rails, without, high, low, to demonstrate the impact on a person's body. And it was really kind of startling. Negative physical outcomes that can put us at risk is a decline in function. skin integrity issues if they're confined to bed, if they're not being able to get out and toilet, and decline in ADLs. And then negative psychosocial outcomes. I don't know if, just from my experience, I don't know if we always consider those in relation to a lot of the things that we're assessing. But having bed rails up can create an undignified self-image and kind of alter their self-esteem and makes them feel more isolated. Next slide, please. So under F700, it addresses the installation of your bed rails. I'm not going to spend a whole lot of time on here, but you consider your alternatives, make sure you've got informed consent, follow your manufacturer's recommendations, check them regularly for loosening and shifting. Actually, we did have a bed rail fall out one time at the place that I was working at and created an injury. And make sure that your folks are conducting their routine maintenance on them. Next slide. So when your surveyors come in, this is the order that they're going to perform their tasks in relation to bed rails. Of course, it's kind of the same for everything, but when they're looking specifically at rails, they're looking at the positioning of your resident, the use of the rail, and how the resident seems to be reacting to the rail. They're going to talk to your resident or their representative. They're going to want to know if they know who requested the rail or recommended the rail. Do they know why it's in use? Do they understand the risks and benefits? And do they know how to request assistance if they need assistance when the rails are up? For staff, they need to know all of those things as well. They also need to be familiar with the resident's functional ability. What are the protocols for the bed rail use and what other interventions have been put into place? The charge nurse or supervisor should know how they're monitoring the use of the rail, whether other interventions have been successful and why, and if you're planning to try to reduce, how are you going to monitor the effectiveness of your alternatives? And again, you can be cited as an RJ if you fail to assess for the risk or provide alternatives and a serious injury occurs. Next slide. All right, so urinary incontinence. Under F690, it states that you must ensure a resident who's continent of bowel and bladder on admission receives care and services to maintain that continence unless their medical condition changes and continence isn't possible to maintain. It also falls under quality of life, where they talk about avoidable episodes of incontinence can be humiliating and degrading, understandably so, and an indicator and contributor to lots of other issues. Next slide. So back to our comprehensive assessment, includes but isn't limited to a lot of the same things that we're assessing for anything else, this time with continence in mind. There are physical conditions that could directly affect your urinary continence if they have, say, a prolapsed uterus or prolapsed bladder, prostate enlargement, significant constipation, distended bladder, bladder spasms, things like that. Diagnoses such as like heart failure or stroke, diabetes, neurological disorders can also affect the continence. And then you've got to assess for environmental factors or assistive devices that might either restrict or facilitate a resident's ability to toilet. All right, next slide. So for citations, when they go to investigate, they're going to do a thorough documentation review, and then based on that, that's how they'll conduct their interviews. That'll guide the interviews. What they're going to have to see in order to cite you is that you failed to provide sufficient care and services, again, to maintain continence, incontinent residents, that you are able to restore their continence if possible, prevention of UTIs and catheterization, and making sure that you're removing caths as soon as you possibly can. Next slide. And then the scope and severity example, an IJ example, I always went with the worst, related to continence. There's actually two here. It looks like it's one big paragraph, but there's two. One is you failed to ensure that a resident who entered the facility with an indwelling catheter was assessed for removal as soon as possible, resulting in the resident continuing to have that catheter in place for 3 weeks, developing a UTI, which led to sepsis. That would be counted as an IJ. Another example is the facility failed to provide appropriate treatment and services for a resident with fecal incontinence, resulting in severely excoriated, ulcerated areas of skin with odor and purulent exudate, and they express severe pain and refuse to get up and leave their room. So those are examples that could be cited as an IJ. I mean, normally I think what I see, this isn't necessarily related to continence, but fall under the dignity tag. I don't know how many times we've been cited for bags being not covered, or, you know, in a infection prevention compromising situation on the floor, not in a container or something like that. That's what I see the most of. But next slide. And all of that was pulled from Appendix PP of the State Operations Manual. I don't know, I'm sure the people in here keep a copy of that downloaded to your computer so that you can search it anytime you need it. But if not, there's a link right there too. And I wanted to mention, not related to what I just talked about, but more going back to Lori's presentation, as I wanted to make sure everybody was aware there's a National Nursing Home Stakeholder Call tomorrow. And I suspect it's tomorrow. Let me look. I think is it 10 o'clock Hawaii time? Oh shoot, my Outlook is freezing. I think it is 10 o'clock your time. Nope, 9 o'clock Hawaii. And my gut tells me that he's gonna address, what's his name? Evan Schulman is gonna address the guidance that came out stating that surveyors don't have to be vaccinated. I don't know that for a fact, but I know that he was speaking at ACA HCA recently and kind of got an earful from folks about that new guidance. And that was recent. And then all of a sudden we have a stakeholder call. So I suspect that there might be more discussion on vaccinations at that tomorrow. And if you need that link, I can certainly send it out.
Great. Thank you very much, Dana. Okay, I'm just gonna, next slide, actually. I'm just gonna go over 2 more slides and then we'll kind of open up real quick questions, I guess. I want to let you know that as hopefully through this series, we're gonna help provide ideas for you to reduce falls, prevent falls, provide interventions. But in the background, Mountain Pacific is gonna be monitoring your MDS data anonymously, of course, and just a group. It'll be kind of an aggregate kind of a thing. We'll be looking at the percentage of short stay and long stay residents with falls and with major injury. That's from section MDS 3, J1700. And next slide. Also be looking at things like functional status, right? And seeing if ADL performance or functional abilities change over the next 4 months, and also looking at bladder and bowel incontinence. Hopefully, more frequent toileting or assistance may help with that and things like that. So just wanted you to be aware, and hopefully you'll be looking at those numbers too to see if we can all move the needle on and reduce falls in nursing homes, and that would be great. So that was a lot of stuff we covered. So I'm just going to open it up, put some questions in the chat if you like, and or just unmute and let us know. Thank you, Gail. She put in a website, nia.nih.gov. Good night's sleep. Hopefully
yeah, the National Institute of Aging. Yeah, I did. Yeah.
Thank you. Thank
You're
you.
welcome. You're welcome.
Okay.
And I just put in the registration link for the stakeholder call. I think hopefully that's not going to end up when I go, I've registered, and when I click it again, it pulls up my information. So hopefully that's not my own link, but I don't think it is. So in case you're not registered for the stakeholder call tomorrow.
Great. And how do we access the slide deck after presentation? It'll be on our website, our website, and under nursing homes, long-term care echo, it should be under that tab. So maybe Michaela can put a link in there. It's not going to be posted right away. I'll probably take a day or two to get up there. But hopefully it'll be useful information for your staff to watch and be more mindful of. Oh, and also Michaela put in a link for the evaluation form so you can get your CEs and your CMEs. All right. Oh yeah, we're gonna have a new website soon, so things might look different, hopefully. Great. All right, well, let us know if, you know, especially in the, when you do your evaluations, if there are things that you would like to see differently, or maybe we could, you have more questions you want to share, or story you want to share next week, let us know. We'll make sure we include you. All right. Thanks, everybody. Take care. And thanks. Thanks, Lori, Gail, and Dana for sharing as well.
Okay, goodbye. Bye.
Bye.